So essentially, I think we have to ask the questions: how low the platelet count will go before you think there's a bleeding problem, so you would like to initiate therapy. I guess that would be the questions. So before I get to that, is just look at where platelet fits into the hemostatic system. I think conceptually, it's actually very important to think about the coagulation cascade is to generate thrombin, to generate a clot, and the clot needs to be removed. That is through the fibrinolytic system and through the generation of plasmin. The platelets actually is there to serve a functions, although not particularly shown in this particular cascade. And I'm going to show it to you where it fits in. Or you can recognize these are the two pathways and then the common pathway in the coagulation system. This is not exactly correct biologically, but it's useful to conceptualize it, especially when it fits into the laboratory testing. Where the platelet fits in is, in fact, provide a phospholipids so that some of the protein complexes can form on the surface of the platelets, as well as for the platelet to release some of the coagulation protein to enhance hemostasis. These complexes can include what we call the TANase, comprises of factor VIIIa and factor IXa, and the prothrombinase that provide the factor Va and the TANase on the surface, so that eventually they generate thrombin. Now, in that context, you can say if there is a drop of the platelet to a point that it will not be able to support these functions, then you will need to treat the patients. The other way to think about it is, it always depends on whether the platelet is functioning or not. So you have to take into account not just the platelet count, but the functions of the platelets. These are the functions of the platelets, and then I will demonstrate it to you. I just go through the slides. Require von Willebrand factors binding to a glycoprotein 1b9 receptor complex. It would adhere to the exposed subendothelium, say for example the collagen fibers. The platelet will be activated with degranulations, as I said earlier in the last presentations. These are the proteins that can be released to help with the hemostasis. And then finally, they will aggregate together through the receptor glycoprotein 2b3 and the fibrinogens. And as the platelet get activated, the phospholipids on the surface of the platelet become a procoagulant surface. That's where the coagulation protein can assemble and subsequently help to generate thrombin and a thrombin clot. So when does the platelet count become normal comparing to an adult standard? In fact, they become very normal at the gestational age of 21. You can see the platelet count is up to about 200 already. So platelet count is easy to remember. Even when a premature baby is born, you expect the platelet count just like almost what we see in the adult patients. However, a neonatal platelet doesn't function as well. As you go down the table, you can actually demonstrate decreased aggregation response to agonists. And all the way down, they're all decreased, except by the time you get to the second last bullet point, it demonstrates that there's an increased von Willebrand factors mediated platelet adhesions and agglutinations. And related to it, it resulted into a shortened bleeding times. So functionally, although the platelets in the neonate seems to be not functioning as well as in adults, however, it's compensated by the fact that the von Willebrand factors has a high molecular weight fractions in the neonatal period. And this is demonstrated by this slide with the very large molecular weight von Willebrand factors under the lane EC. So with that compensations, you'll be able to appreciate in these bleeding times at a young age, 0 to 2 or 2 to 4, the bleeding time is shorter than the adults. If you take bleeding time, it's assessments of primary hemostasis, despite the fact that the functions of the platelet is relatively hypofunctions in neonates, they function better than the adults. So when you think about that, even if you achieve the same platelet count in the neonate and the adult, the hemostatic level may actually be slightly different related to the function that comes along with it. And I want to make a point again is, it's not just the platelet count alone, you have to take into account of the platelet functions. So when the platelet is low, then one of the reactions is whether you should transfuse them. I guess that would be the questions. Transfusions of platelets. It actually to achieve a couple of things, to prevent hemorrhage or to treat hemorrhage related to thrombocytopenia or platelet dysfunctions. And there's some contraindications to them, like a TTP, HIT, or ITP. Contraindications to platelet transfusion is ITP is relative. In the absolute emergency, you may still transfuse it. It's just not going to be very reactive. Now I'm going to use the ITP as an illustration of how low a platelet count can go. This is a review article published in 2011 looking at the practice guidelines for ITP. What it demonstrates in that review article is there's no randomized controlled trial using significant bleeding event as a clinical outcome. And from that, there is no trial that demonstrates by treating the patients to elevate the platelet count to demonstrate there's a significant decrease of significant bleeding at the follow-up. Okay? And in fact, when you look at ITP, the platelet count can get very low, below 10, but there's no correlations exactly related to the fact when the platelet count drops, these are the patients who's going to develop the intracranial hemorrhage that you worry. So the recommendations from this review is children with no bleeding or mild bleeding will be managed with observations, disregard of the platelet count. So in fact, you can allow the platelet count to drop down to very low. The decisions to treat really based on the decisions whether the patient is bleeding or not. So this actually gives you the first glimpse. And I'm going to look at the specific populations, the neonate, the critically ill patients, children with myelosuppressions, and patients requiring anticoagulation therapy. These are the recommendations in adults. It actually say major or invasive procedures, you transfuse them if the platelet count is less than 50. If it is involving an organ that is more sensitive to bleeding, say for example, eye or neurosurgery, suggest 100. Patient with ongoing bleeding, in general, feel that if you have the platelet count above 50, that should be adequate. In very unusual situations, you may require the platelet count to be above 100. For a patient that is stable with no bleeding, they suggest to be less than 10 before you do any transfusions. So you may conclude, well, maybe you can go as low as 10. And then with the patient that is stable but with other medical conditions, say for example a fever, and they suggest maybe you have to transfuse the platelet above 20. What happened to the neonate? Because as I said earlier, I think they are different. The recommendations, again, depending on whether it's a non-bleeding neonate or the patient's or neonate that is having a bleed, or a patient with neonatal alloimmune thrombocytopenia. Despite the fact that the bleeding time is lower, I think people worry about bleeding in neonate, especially related to intracranial hemorrhage. That's why they adopt a platelet count to be higher, to suggest that when the platelet count drops below 30, you shall do a platelet transfusions. And then for the platelet count between 30 to 49, then depending on the conditions, you may consider to transfuse. So it sounds like we are being more aggressive in transfusion neonate because we worry about intracranial hemorrhage. Then look at some of the data. This paper published in 1993, really looking at whether you can transfuse platelets to obtain a normal level to decrease the risk of intracranial hemorrhage. This is a randomized controlled trial, but try to achieve a platelet count of 150. In the first three days of life, with a platelet concentrate of 10 ml per kilo. In this particular trial, what it demonstrated is when you transfuse platelet, you can shorten bleeding time, but there's no suggestions that you can prevent intracranial hemorrhage. You may also ask, why would you like to adopt a lower threshold when you can transfuse platelet? Because there's complications related to platelet transfusion, and this is a list of them. Right at this moment, there's no data to tell you exactly what platelet count is safe, and that comes with the what they call the PLANET trial. Neonatal transfusion study number 2 is a randomized controlled trial to compare 2 different platelet count thresholds, 25, which is taken as a standard of care, comparing to 50. And this is a randomized controlled trial which is ongoing. And the outcome of this trial will include neurodevelopmental outcome, will be classified to mild, moderate, and severe, as well as mortality. So this is a study to be watched for, because eventually at least it will help to tell us whether it's going to be better to transfuse the patient at a higher threshold or at the standard of 25 at the present time. So you can actually decide what to do right at this time when there's no study, because at least when the randomized controlled trial is ongoing, which means it's an equal poise. You can either pick 50 or you can pick 25. Now look at the critically ill patient. This is a systematic review to look at the platelet transfusions for critically ill patients with thrombocytopenia. And I'll just go to the conclusions. It's a systematic review. One interesting result is you can actually find more trials in the neonate comparing to in adults. And this is actually one rare situation, because most of the time we have more randomized controlled trials in adults comparing to pediatrics, but in here it's actually fairly different. But what it comes down to is there's not enough evidence to tell you whether you should transfuse those patients to prevent bleeding, be it in adults, ill children, or ill neonate. So in some way, you can let it drop as low as you want, as long as they're not bleeding. Now, absence of evidence doesn't mean that you should not transfuse, though. It's just the fact that there's no data to suggest that you should transfuse them. Okay. And so this is what I alluded to earlier. In the absence of data, this is what you can consider to do for the premature neonates. How about in the cancer patient? This is a study done recently in my own institutions, looking at a cohort of patients for looking at RBC and platelet transfusions. And one of the data I want to show you is at what point are those patients being transfused, at what platelet count? And what we found is the median platelet count before the platelet transfusion is being ordered is 16. So at least in practice, this is where we're actually running our platelet count, and I'm going to show you this data in this slide on the graph. So the median is somewhere around 11 to 15. So the oncologists, and I'm one of them, allow the platelet count drops down to somewhere around 10. Everything being equal, the patient is stable and non-febrile. If the patient is sick, of course, if they're bleeding, we will transfuse them earlier. That's why you see the spread over here as well. But majority of the time, we don't transfuse them until they're almost down to 10. Now, having said that, all we can say is this is our practice. Exactly whether this is the right thing to do, I think we still require more data to show us. And that comes to 2 meta-analysis in the Cochrane review.
4 minutes is left.
Yeah, whether there's a therapeutic only versus prophylactic platelet transfusion strategy for preventing bleeding in the hematological disorder with myelosuppressions. Right at the present time, there's low to moderate data to suggest therapeutic only platelet transfusion policy is associated with an increased risk of bleeding. So which means suggests to us potentially we should use a prophylactic approach. But what exactly is the level the prophylactic approach should be and what platelet threshold to use? And this is this Cochrane review. And what I want to demonstrate to you is There's no evidence at the moment to suggest a change from the current practice of using platelet count of 10. So 10 seems to be okay. However, the evidence to suggest 10 is a safe level is not as solid as we think. There is some experimental data to suggest why 10 is the case. This is actually published way back in 1978. Looking at stool for occult blood on the on the y-axis and the platelet count on the x-axis. You can see the amount of stool occult blood drops substantially. By the time it gets down to around 10, it's almost become flat. At least by this data, it may suggest 10 may be okay, but we require more clinical data to demonstrate it. How about thrombocytopenic patient requiring anticoagulation therapy? These are again fairly little data. In the adults suggests you should keep the patient platelet count above 50 if you want to anticoagulate them fully. In my practice, I think in a child, the blood vessel is healthier. We allow them to drop down to about 30. If it is below 30, we either adjust the anticoagulation therapy or we transfuse them with platelets. So this is the conclusions. I think platelet transfusion threshold for prophylaxis remains to be determined, but it depends on the etiology of the thrombocytopenia, depending on the circumstances, say for example, the type of surgery, the tolerance of risk, and the clinical status, and there's much research to be required to address that questions. And then I'd like to stop here. Thank you for your attention.
Thank you, Professor Chan, for your two nice presentation, and I'm sure that the general pediatrician has taken take-home messages from this two marvelous lectures. And the door is open now for discussion and questions.
Good afternoon, Dr. Anthony. This is Dr. Bharat from Pediatric Department, Jara Hospital. I have a question regarding CBC interpretation and peripheral smear. First question, premature cells in the peripheral smear, very occasionally we get in the report. So how to interpret and what is the importance? One. Second question is leukoerythroblastic anemia. So what is the importance of this with relation to the clinical picture? And third question is iron deficiency anemia with thalassemia. Is there any specific changes can we see in the peripheral smear with CBC?
Maybe I answered the last one first. The iron deficiency in thalassemia, I presume these are thalassemia minor and that is not being transfused. In those patients, I think they still should be receiving iron supplements, because I said earlier, iron supplement not necessary as a medicine, but to be sure they have enough nutritional iron. The main reason is iron itself has much more impact than just making a hemoglobin, because neurodevelopmental outcome. The key thing would be is just to monitor them so that you don't overdose those patients. The second question was related to the report of the leukoerythroblastic anemia. Those are transient, in some way has little relevance in terms of a long-term impact. It's a transient phenomenon that you will see them. I have to apologize. I missed the first questions. I didn't hear them quite well. Would you be able to help me again? The first question?
That was premature cells of all three lines, platelet, WBC, and RBC.
So in immature infants, the WBC and the RBC.
Yes, sir.
Right.
What is the importance and how to interpret in moderate to sick ill child?
Yeah. So I'll address about the RBC first. I think the question will be related to the fact, when do you require to transfuse them? I think the transfusion threshold for RBC in the premature babies is still controversial in some way. I think it gets to a point is there are a few parameters people would like to use, and then the neonatologists in audience kind of correct me and have inputs when you like. One is whether the baby is growing and feeding well enough, whether there are other You can save the safety margins to leave the patient at a certain hemoglobin, because, say for example, if there's a good chance the patient may bleed, you may like to have the hemoglobin top up because you don't have a lot of safety margins. Or whether there are other physiological response of the baby that suggests to you the baby is not tolerating the hemoglobin level that he's at, say for example, tachycardia and feeding. In terms of the white cell, I presume it's related to the fact whether they are actually as indications, they actually have infections or not. I'll go back to the presentations yesterday. I think one key point that was brought out yesterday was if the lymphocyte count is less than 0.5, then you actually have to think about whether there is a primary immunodeficiency. The rest of it is, there's not a lot that we can say, for example, to do in terms of the white cell transfusions. So in those situations, it's mostly reacting to the conditions that cause the decrease of the white cell count.
Since nobody is having questions, I have small questions about the use of Revuelade in chronic ITB, especially that nowadays it is FDA approved and it is licensed to be used in children. So I'm not talking about Nplate now, I'm talking only about Revuelade. If you have any experience with that.
With the thrombopoietin mimics.
Yeah.
So we have used it in occasions. Particularly, we use it within the clinical trial context in those patients with chronic ITP. And then we also use it in occasions we more or less lost all our, you can say, therapeutic options. Then we use it. And I'll give you an example. Lately, we have oncology patients with a CNS tumor post chemotherapy. The platelet count just wouldn't rise, stay down at about 5. Refractory to platelet transfusions, as I said earlier, which is a complication of multiple transfusions. Had a big spleen, we do a splenectomy. Platelet count goes up and drop back down again. So you eventually do use these thrombopoietin mimics, and then at times you will see some success, and in some way you can say it is therapeutic trials. As I alluded to the last presentations, with some of those modern analyzer, you actually see platelet count, whether they are immature platelets or not. I suppose if you see those that actually have more immature platelets, as it says to you, a destruction mechanism is there, at least the current thinking is maybe you can drive the bone marrow to work harder, and in those situations it may be useful. But of course, you have to have enough time for it to have the response. Depending on the situations, when we used it, we can actually even see it within a week that we will see the platelet counts to go up. And people are in fact thinking about, say for example, even in the critical care units, whether you can prophylactically, as you see the platelet count drops, and then you give the platelet, these thrombopoietin mimic first before you require platelet transfusions. Yeah. And as I alluded to earlier, multiple platelet transfusions, at least in the neonatal period, is associated with a higher mortality. It's associations. We don't know it's just because they're sick, they require more platelet transfusions, or the platelet transfusion in itself, as a complications, increase the mortality. If it is the later case, there may be a good reasons to think about trialing these sort of mimetics in a clinical trial context. Yeah.
Thank you, Dr. Chen. Sorry, may I have one here? Thank you, Dr. Chen, for your presentation. I have one question regarding dilutional anemia. Sometimes a patient comes for an infection process, let's say pneumonia, and CBC was done for him. The next day there was, let's say, a significant drop, 2 or 3 grams in the hemoglobin. So how would I know whether this is a dilutional anemia or because of the underlying process that the patient came with?
It is actually a fairly common phenomenon, especially I'll go back to the oncology patients. They come in with febrile neutropenia, and the current standard is you give them about 1.5 times maintenance, you see the hemoglobin drops. It's pretty hard to differentiate. I guess you have to kind of take into account when the patient is being admitted, whether the assessment is the patient is relatively dehydrated, and then looking at the amount of fluids that you give. And furthermore, you may just have to kind of watch it a little bit more to see whether there's further drops or whether there's signs that suggest to you there's a cause, say for example, ongoing bleeding on hemolysis. Otherwise, you can continue to watch. And in fact, with these modern, with the analyzer, that actually gives you more information. At times, by using those informations, you can tell whether when the patient comes in, the patient already has an iron deficiency or not. They may have an iron deficiency but no anemia, but when they're critically sick, in some way you can think about the bone marrow is somewhat shut down for a short period of time if they're relatively sick, but at those point of time, when you start giving them iron as a therapy, so that actually potentially can prevent some of the blood transfusions going in the future. But those needs to be further investigated, but that is the advantage of using those analyzer, can give you the retic hemoglobin as well as the immature platelet fractions.
And what about hematocrit in this situation?
Pardon me?
Hematocrit in this situation, is it helpful?
I take the question is how to use the hematocrit to decide whether to transfuse or not, right? It gets down to therapy. Is that the questions?
Regarding the dilutional anemia, because the hematocrit also is,
Yeah, well, they would also drop, of course. And then, of course, by the time you're actually in those situations, whether you decide to transfuse or not, we actually have a very conservative approach. Most of the time, the threshold, say even 70, is we start thinking about whether to transfuse or not, but most of the time we don't. If it is a situation that is transient, we feel that the patient is tolerating the anemia quite well, we in general don't transfuse them. In fact, I was asked, how low has the hemoglobin gone down to, and that I didn't transfuse? It was down to about 40, about 30, but those are due to iron deficiency anemia related to drinking too much cow's milk. So you can actually get a hemoglobin to very low. In those situations, you know they're going to get the response rather quickly, and they're not at risk of further decrease of the hemoglobin, and the patient is tolerating it. I think in those situations, you don't need to transfuse them.
Thank you very much, Prof. Chen.
Thanks again.